I am not a health economist. For those of you of a certain age, you might be reminded of Star Trek and Bones McCoy, saying, "Damn it, Jim, I know nothing about health economy." But I'm going to look at this more from an eyes of a clinician making practical decisions. And what I want to do is sort of frame the situation as, given branded imatinib and the second generation drugs, what are the decisions that we should use rationally to pick which patients should get imatinib and which should get tyrosine kinases? And then now that generics are available, can we just sub in where we would do branded for the generic and have that make enough of an impact rather than just having everyone wholesale take imatinib, a generic, and then just switch over in case you really need to. So I'm going to take more of an approach of there's different right things to do for different types of patients. We have to be doctors, we have to use common sense. So here's my attempt to do that. So the first thing you have to realize, and everyone shows this, is that we have made unbelievable changes in the natural history of this disease. And this is a chart showing by decade of chronic phase CML and life expectancy through various periods of time. So down here, you've got natural history of nothing, and then busulfan. And then you have interferon plus Ara-C. And here's what we have now with the second generation drugs. So there are pharma people in the audience who worked on these projects. You should give them a slap in the back of congratulations. Frank Giles is in the audience, who was really instrumental in doing a lot of these early trials. You should give him a high five, because this is just the remarkable difference in the natural history of the disease. It just goes to show the power of when you have a drug that hits a target and you have a target that you can actually monitor as disease burden, and how those two things can impact how you take care of a disease. So this now looks at relative survival of people in chronic phase against natural history of people without CML. And you can see for almost using measures of all patients or only those that get complete remissions or those that get a major molecular remission or CMR, all of these are virtually within 95th percentile of the normal population, which is just absolutely astonishing. One of the main reasons we've done this is we've become very, very good at keeping people from getting into accelerated phase and blast crisis. So these are charts that look at the cumulative incidence of blast crisis through the era of busulfan up here. And this is just sort of like mirrors that other thing I showed. As you march through the decades and you get through to the imatinib era, we have basically changed the natural history of people progressing to accelerated phase and blast crisis. And that's where the huge strides have been made. Right? Before, with interferon, virtually everyone would march into accelerated phase of blast crisis after 5 years or so. You couldn't cure people in blast crisis. You actually can't cure people now in blast crisis besides transplantation. Our therapy of that has changed nil since the 1970s. But we can keep people from getting there, and that really has to be your prime responsibility as a patient taking care of someone's CML. Because this is what happens when people go into accelerated phase of blast crisis. This is on people from the IRIS trial, which was the randomized trial of imatinib versus interferon, and the other was eNESTIN-D, which is the randomized trial between nilotinib and imatinib. Once people go and progress on TKI, their median survival is less than a year. So that's why we have to be diligent. That's why you treat people aggressively. That's why you monitor them molecularly, is to prevent that from happening. So we now have an embarrassment of riches. The FDA has approved 3 different drugs frontline: imatinib, nilotinib, dasatinib. Second line, we have even more. We've got nilotinib, dasatinib, bosutinib, ponatinib, omaxitaxine, which, showing my age, when I first started, was named Homo Harrington. So it's still kind of looking for a disease. Allogeneic transplant, and then some other options. Now with the NCCN guidelines, we have these nice flow charts that are sort of generic. This is what we would do for this imaginary patient. But I think really deciding what TKIs you start people on really depends on what your goals are for that patient. Is it to lengthen survival? Is it to prevent progression? Is it to get someone into a complete molecular response so you can potentially get them off therapy? Considering their comorbidities and drug toxicities, and considering the compliance issues, frequency of use, restrictions, things like that. All those things play in about which drug you should take. Because the treatment goals vary. If we want early molecular response, that means hitting of a certain target by 3 to 6 months. Why is that important as a treatment goal? Because we know that it has an effect on progression and survival. Why do we want to get someone a complete cytogenetic response? We know that has an effect on progression and survival. Why should we push people to get into a major molecular response, a 3-log reduction in BCR-ABL? We do that because we know that's a safe haven. When people get into an MMR, if they stay on drug, they almost never progress or become resistant. So that's really a milestone of therapy that when someone's doing safely. And why do we want to get them into a deep or complete molecular response? I'll show later. There's now evidence you can take people off drug in those conditions. So depending on what your response goals line up on how you would use them for your treatment goals. Now, this is I say a somewhat bogus comparison because you shouldn't really compare us in 2 different randomized trials, but I did anyway. This is the dasatinib trial, the decision trial, which was dasatinib versus imatinib. So that's the response there. And then this first one here is the imatinib arm. This is the ENSND. So this is the nilotinib arm of that, and this is the imatinib arm in that. And the thing that you can notice, which is really quite remarkable here, these are 2 different trials, but the imatinib 400 milligram arms are alarmingly, amazingly similar for all of those criteria. Look at their 12-month complete cytogenetic rate. Right? Look at their 5-year major response rate to 4.5. Look at their survival. They really are amazingly similar across trials. And so what you can see then, comparing the second generation to the imatinib, is the complete cytogenetic response rates about 10 percentage points higher. The major molecular response rates and deeper response, 4.5, are higher. A number of people who get below 10%, which I'll show you is kind of a magic cutoff, is higher. Accelerated phase blast crisis progression is lower, but really makes not much of a difference in survival. So short-term response, better. Major molecular response, better with the second-generation drugs. Being able to get into a response deep enough to get off drug, better. But overall survival, you can salvage enough of them that it really doesn't make that big of a difference. So in which patients would that be useful for? Oh, and here is the intergroup trial. This was the Southwest Oncology and the other intergroups. We had to do this in 2 phases. So it was first done imatinib 400 versus 800, so that's those arms. And then the second phase was dasatinib versus imatinib 400. The dasatinib versus imatinib 400 are virtually identical to the decision trial. It's unbelievably similar. The thing that's kind of interesting here is that in the imatinib arm, versus 800 versus 400, imatinib at 800 gave almost the exact same results as the second generation drug. And that's been seen in many other trials. The difference is that imatinib, once you get up to 800, you lose a lot more people for toxicity because if you have some toxicity imatinib at 400, there's no way you'll get someone up to 800. So that's the cost of that strategy. So let's go through a couple of these things. Here's early molecular response. This is the first study that was shown at the Hammersmith, and it shows that basically when you're diagnosed, your BCR-ABL in the peripheral blood is roughly 50% to 100% international units. So at a landmark analysis at 3 months, if you were above the 10% mark, there you are at 93%. But if you don't hit 10% by 3 months, there you are down here. Now this is a little bit different than some of the other trials will show because this was a period of time in England where they couldn't get second generation drugs. So this group was sort of doomed to kind of flail away with whatever they could find beside another tyrosine kinase. This just shows that data and others. And again, in areas where you can get second generation drugs, the effect isn't the same as big. But in all of them, it shows a direction that you would rather have a good response at 3 months than less. And that isn't really rocket science at all. The worst groups are the ones that have a bad result at 3 months and continue having a bad result at 6 months. Because at 3 months, there's 2 reasons where you cannot respond very well. One is that you have bad biology. And the other is that because you've just put a person on drug, they're having a hard time taking it. They only take it intermittently, so they really haven't gotten a fair shake of actual drug exposure, right? So because most patients with CML aren't sick when you first diagnose them, anything you do to them makes them sicker than they are when they walk in the door. So they're not very tolerant of taking drugs that have side effects, right? So the worst group here is this one here, down here, which is the greater than 10% at 3 months, and then they're still greater than 10% at 6 months. This is data out of Adelaide. So if you look at the other groups above that, they're 100%. This goes down to 60%. And then if you talk about major molecular response, which we said is a safe haven, if you're these criteria here, you have 88%. But if you haven't hit below 10% at 3 months and at 6 months, you're still above that, your chance of getting a major molecular response is less than 5%. So that's clearly a warning sign to do something different. Now, all these tyrosine kinases have different spectrum of toxicities, which you all well know. The major common ones are myelosuppression, although Imatinib really doesn't do that very much. You can actually give Imatinib day 28 after an allogeneic transplant, and it doesn't affect the counts, which I think is a pretty darn good proof that it doesn't have any primary hematopoietic toxicity. You can't try that trick with the others. But the main one that's toxicity that's come into light recently is the issue with venous and arterial vascular events. So this is the ENUS in D trial, looking at cardiovascular events. This is the Imatinib group here. Imatinib cardiovascular events are really about the same as the general population. In fact, some people think it might be protective. And these are the cumulative incidence rates with the 2 doses of nilotinib. This is a class effect. It's basically seen in all of these other tyrosine kinases, although we don't have nearly as much data with bosutinib. But if you look at the worst one offender, obviously the reason that the FDA called them in was that it's much higher with a ponatinib arm. So the other issue we talked about was compliance. Now I kind of showed this, so I kind of forced my hand. But you would think that these drugs, they're remarkable. They change the natural history. They don't have much toxicity. I'm a transplanter, so they really don't have much toxicity compared to what I usually have to do to patients. You would think that this would kind of change the natural history and people would willingly take their drug almost to perfection. It's actually not true. This was a study that was done in England where they actually had people raise their right hand and say, how often do you take your drug? And basically 70% of people said, I faithfully take my drug religiously every day. Unbeknownst to them, they had a radio frequency device in the capsule of their pill box, so they could actually monitor every time they opened their pills. And using that and basically pharmaceutical records, they found that in fact 14% of patients actually religiously took their drugs, which is pretty darn shocking. Another reason, of course, that you may not take your drug is you have a giant pill to take. So this is Tim Hughes' head. So this is an international pill size of about 0.3 Hughes units. So this is, I show this because this just shows kind of how bad we've gotten, the lawyers. This thing right here, this little line actually says not actual size. So in case you imagine that people actually had to take giant pills in their backpack and gnaw at them all day, right? That would certainly spoil compliance. But compared to the alternative in CML, which is transplantation, this is a month of an allogeneic transplant's patient's pills. So, I honestly pulled this trick. It's kind of mean. But if I have a patient who I'm trying to emphasize the need to taking their CML drugs, I make sure that I do the clinic visit in our allogeneic area so they get to see lots of people with chronic GVHD and the like, to see what the alternative is that, for taking your drugs. This is immensely important because we've spent a lot of money on second-generation tyrosine kinases and the like, where actually probably what we need to do is to make people take their first-generation tyrosine kinase. This looks at complete molecular response rates and CMR rates. That's this complete molecular response rate. This is CMR. On whether or not you took 90% of your prescribed Imatinib or not. And so if you take 90% of your Imatinib, your major molecular response is 90%. If you take 90% of your Imatinib, your complete molecular response is 40%. So taking your drug probably trumps all other indications of what drug to take. So one of the final things to talk about before talking about how to fit in which drug to which patient is what we now know about discontinuation. When we first started treating people with these drugs, we figured that they would be on them for life. Because when you take CML stem cells, if you believe kind of in that religious concept, and put them in the lab and sprinkle tyrosine kinases on them, they do nothing. They just look at you and kind of divide slowly and the like. You can't kill the CML stem cells with tyrosine kinases. So since that's true, we figured, well, heck, these people have to be on drug for life because you'll always have a reservoir like HIV, and you'll never extinguish all the stem cells. And there was a bunch of math models that were done. I'm responsible for doing these as well as other people, where you find that with either imatinib or other second-generation drugs, you first get this fast slope of CML cells disappearing, which is thought to be from the committed cells. And then you get this other slope here, which you suspect is the stem cells cycling through. And from that, you can do a bunch of models. And these two numbers are based on two different assumptions, which would map out that it's going to take at least 30 to 40 years to eradicate all CML in patients. And that your cumulative cure rate after 15 years of therapy would only be 14%. So if we saw that, we would never think about doing a discontinuation trial. Fortunately, some of the people who did the next trials hadn't read that literature, and in fact, tried to discontinue people off drug. These are people who had been on drug at least 4 years, had been in a complete molecular remission for at least 2 years, and you found that about half of them would stay in PCR negativity now up to 4 years. This blew everyone's mind, that you could actually think about taking people off drug. And this is fantastic, because young people you can take off drug, right? They could have children. You can imagine people getting off drug and saving lots of money. This is a fantastically big thing. So this is now kind of grown into a growth industry. And there are a number of trials here and abroad looking at discontinuation, changing it a little bit on what drug you took and how long you've been in molecular remission and the like. But the same theme is basically the same. Roughly between 40 to 50% of patients remain off drug for years. So what can we say after all those slides? That imatinib is equal to second generation in overall survival, that deep molecular remissions with the second generation drugs happen more than with second generation tyrosines more than imatinib, and that can be somewhere around 40%. There's some evidence that if you start on imatinib and switch, you'll get up to 40% on a second generation drug. Discontinuation is equally successful for all TKIs. It doesn't seem to matter what TKI you use to get into a deep molecular response. As long as you get there, that's the important thing. Imatinib looks to have the same effect as second-generation tyrosine kinases in lower-risk CML by so-called scores. It probably is a little bit more favorable in high-risk scores, second generations, because those are people who are likely to progress to accelerated phase and blast crisis. And there are certainly long-term toxicities. We worry most about the vascular, which would favor imatinib over tyrosine kinases. So I can't talk about generics without saying something about cost. I really don't know a lot about about quality-adjusted life years, except that it sounds like something that I want a lot more of. But there's been a number of studies that have looked at overall survival differences between second-generation drugs and imatinib, and they estimate that for every additional year of life you get by a second-generation drug would cost you about $800,000, which seems to me, as someone who knows nothing about this, as to be pretty high. We have now one generic drug out there. It's still in its 6-month exclusivity clock. It's about 90% of generic price right now. Typically, when they're on these 6-month things, they run from 70 to 60. But we should expect a pretty big drop. If you look at about generics across the board, once you get more of them out there in the marketplace, they're about 40% of the branded cost. If there's more than 3 generics out there, it's usually about 15%. In Canada, I believe there's 4 generics. And depending on what generic you're in and what province, it runs about 15 to 25% of the branded cost. So substantial life savings. So what would be the issues with using generic? Well, generic imatinib would be obviously good, cost-effective for long-term use, right? But the second generations are better at preventing accelerated phase and blast crisis. It's very expensive to go into accelerated phase and blast crisis. You don't want people to go there because they'll probably die. The second generations are better at deep molecular remissions, and if you can get people off drug, that obviously is a huge economic self-interest. And could you actually build a cost-effective strategy with just high-dose imatinib? Maybe, maybe not. But I think the bottom line is the use of generic imatinib should be guided by the treatment goals. Now, you can make this argument about cost of tyrosine kinases, and you can kind of take it to the absurdity. I often like to take arguments to the absurdity. So I was listening to someone debate about costs it would take to get treatment or free remissions in patients with these various tyrosine kinases. And the argument was something like this. If you had 3 years of treatment and then you took 2 years where they'd have to be in continued treatment to get to CMR, at 100,000 years, that's 500,000. 40% get enough of CMR that you would try discontinuation. About 5 of them would stay in treatment remission after that. It works out to about $2,500,000 for every patient who you get in a TFR. If that's really your only strategy, you should go back to transplant. I would never advocate going back to transplant, but if TFR is what you want, transplant's a lot cheaper. Transplant in 3 years of chronic GVHD is about $1 million. Your survival rate's 85%, your TFR rates are 90%, so you're about a half of what it would cost to do this with drugs. And in fact, many developing countries, for that reason, choose transplant over TKIs. How we use these, we've been trying to do this trial with various pharmaceutical companies for ages. We've gotten nowhere, because what you'd really like to know is how to basically use the generics. And you can think about 2 strategies. One is you use a generic, and then you have very rigorous milestones, and you only switch to second-generation drugs in cases that don't hit those aggressive milestones, and you cross over. The other would be treat them like an acute leuk. Give them a second-generation drug as an induction therapy, and then when they hit their milestones, switch them over to the cheap generic, because they'll be on that for years. Right? So those are the 2 strategies. We have never been able to go anywhere with getting that thing done. So I talked to a mathematician that I know, and she basically did this study in silico. So this is basically called a Markov simulation, and what you do is you take every possible first-line agent and every possible scenario of hitting EMRs or not, and then what drugs you could possibly switch over, and adding in all the data in the literature of what survival rates are, what failure rates, the whole rigmarole. And then compare all those models. And what she found is that the winner by quality age-adjusted life units is giving induction therapy and then giving Imatinib generic for as long as possible. We haven't built discontinuation into the model yet, but stay tuned. So, with apologies to the Tubes from 1978, classic song, what do you want from life? We want cheap meds. If that's what you want, use generic Imatinib. To not have an MI, exercise, and then use generic Imatinib. To prevent blast crisis, use a second-generation TKI. If you want a CMR and TKI discontinuation, use a second-generation MI. And if you want your cake and eat it too, maybe high-dose Imatinib. So this is my guess of what things will look like in 2016 and beyond. Generic Imatinib for low and intermediate risk disease, that's fine if you want to just extend survival. Generic Imatinib for older, sicker patients. Older patients, you're not trying to get into a complete molecular remission and get them off drugs so they can have kids, right? You want something that's not toxic, not cardiovascular toxic. You're just trying to extend their survival. Second-generation drugs for high-risk SOCL, because you don't want them to go to accelerated phase and blast crisis. You could turn them on for MMR and then go to generic, or if you're the nervous person like myself, you could just keep them on that indefinitely. And second-generation drugs for the younger patients in whom you want to discontinue the drug. And with that, I will end. Thank you very much.